Okay, welcome back, guys, to Individual Module 5.1. This is PowerPoint 2 and Lecture 2. And we're going to continue this lecture and talk about the physiological changes that happen during pregnancy. And just like it says here on this slide, a woman's body will never be the same again. So let's find out why. So the reproductive system itself actually changes during pregnancy. The uterus will enlarge from about 2 ounces to from what it normally is to about 2.5 pounds. So that's a big, huge jump. Just some additional weight to carry around. The cervix changes. It develops something called an operculum, and this is just the mucus plug that a woman develops in the cervix to keep the germs and bacteria and infection out of the uterine cavity. So it's just a protectant. And then we have Goodell sign, and that's the softening of the cervix that we talked about earlier. The woman stays in a physiological state of amenorrhea, so no period. The vagina becomes a little more acidic, and we can also see Chadwick's sign. That cervix, the vagina, and the vulva get that nice bluish tint. The ovaries don't ovulate, and this should make sense if you think back to our lecture on the female internal reproductive system when we talked about hormones, because of that negative feedback system. Our body has no need to mature any follicles to ovulate because our reproductive system has already accomplished its goal, which is pregnancy. So our body doesn't need any more periods of ovulation. So our ovaries do not ovulate during pregnancy. There are breast changes that happen as well. Breasts become larger during pregnancy. They become more vascular, and they start preparing themselves to breastfeed. Milk ducts swell up. And some individuals may actually see colostrum by the 16th week during pregnancy. And colostrum is that very first bit of breast milk that moms start to make. Some people call it liquid gold. It's very thick, kind of yellow in color, has lots of antibodies in it that will pass on passive immunity to a newborn baby. Lots of nutrients, very rich type of milk. All right, so the uterine growth that happens during pregnancy obviously happens gradually and as the baby matures and grows. So we can use a measurement method that we talked about earlier to sort of estimate how many weeks the baby is based on McDonald's measurement method. Sometime between 20 and 22 weeks, the top of the uterus or the fundus should be able to be felt around the umbilicus. If you look at this picture here, it shows you how the uterus should progress. If you notice, 36 weeks is higher than 40 weeks. And this should make sense because as the pregnancy continues to grow, it'll reach its highest point at around 36 weeks, and you can see that's right there under the xiphoid process. So at 36 weeks, that's where we should be able to find the fundus of the uterus. But sometime between 36 to 40 weeks, really 38 to 40 weeks, a mother starts to experience lightening. And lightening is a term that we use in OB to describe when the baby drops. The pelvis starts to open up and prepare itself for labor and for the baby to pass through, and that allows the presenting part and the baby to kind of drop down into the pelvic cavity some, which in turn will drop the fundus of the uterus down. So that's why you see 40 lower than 36 in this picture. Now, whenever we do McDonald's measurement, we actually use a measuring tape for this. We put the end of the measuring tape on the very top of the symphysis pubis, and we stretch that measuring tape up to the fundus of the uterus, and we measure that out in centimeters. And normally your centimeters will correlate with the number of weeks, roughly, from about 16 weeks to about 36 weeks. So just by measuring the centimeters from the symphysis pubis to the fundus, you can sort of figure out very quickly, at a very rough estimate, what the gestational age of the fetus is by doing McDonald's measurement. So let's talk about how the integumentary system changes during pregnancy. Here are some pictures that you need to take a close look at, and we're going to talk about them. The first thing that probably the majority of women have in terms of integumentary system changes are striae gravidarum, and those are stretch marks. So this is the middle picture on the right-hand side of your screen. Many women end up with these striae gravidarum. Oftentimes they do not go away. Usually they will fade in color, maybe, that they will not go away. Sometimes during pregnancy you will see them look nice and red and streaky. Some of them even have a little purplish tint to them. And then after pregnancy, as the skin starts to shrink back down, a lot of the times that redness and that purplish look will fade away, and they'll be kind of white and silvery like normal stretch marks. The next one is the linea nigra. Linea nigra is this top picture on the right-hand side, and this is the dark hyperpigmentation that occurs in a line right down the middle of the abdomen in a vertical manner. And you normally see this on darker skinned individuals, people that have a little more melanin for whatever reason. Sometimes this will fade and sometimes it will not, just depending. Number 3 on your screen here is chlasma. And chlasma is also known as the mask of pregnancy. This is another hyperpigmentation syndrome that can occur during pregnancy. And the woman with the eyes blacked out has chlasma on this screen. You can see that she's got some hyperpigmentation around her face in a mask-like characteristic. So this is what chlasma looks like. PUPS is the picture that you see down in the bottom right-hand corner, the little nice-looking rash on the abdomen of this lady. And PUPS stands for pruritic urticarial papules and plaques. It is a very uncomfortable condition of pregnancy, and it is very itchy. The woman just gets this rash pretty much all over. Usually it starts out in the abdomen area, I believe, and there's not really much that we can do for it to treat it. Some women might end up with red and itchy palms. Some ladies might have vascular spiders that occur, and vascular spiders you see in this last picture on the slide, the top one on the left-hand side. And Then most women have hyperactive sweat and sebaceous glands, so they may end up with acne that they don't normally have. They may be more sweaty than they normally are. The respiratory system also changes in a pregnant person. Pregnant women stay in a state of respiratory alkalosis. And the reason is because they have an increased oxygen demand. And because of that increased demand or their increased need for oxygen, they consume more oxygen. And because they're breathing in almost 30 to 40% more than normal, they have an increased CO2 production. They breathe off more CO2, and they end up in this state of respiratory alkalosis. So let me repeat that again. They breathe more, okay? They have an increased demand for oxygen, so they are doing a lot more breathing, meaning that they're blowing off more CO2, which causes their CO2 levels to drop. If their CO2 levels drop, then their pH will increase, and they end up in this state of sort of sustained respiratory alkalosis. Many women have shortness of breath as the pregnancy starts to grow. This should make sense if you think about how we breathe, right? The diaphragm has to be able to expand for us to take nice, big, deep breaths. And in pregnant women, the diaphragm cannot expand like it is used to expanding. So pregnant women move from a state of abdominal breathing to a state of thoracic breathing. And usually until lightening occurs, they tend to be a little short of breath. Also, pregnant women may experience chronic congestion or epistaxis, and that is just because of estrogen, and that tends to make people have edematous airways. Okay, so let's move on to the cardiovascular system. This is another system that does a whole lot of changing during pregnancy. Blood volume increases a lot during pregnancy. The plasma volume will increase by about 50%. Cardiac output will increase by about 50%. Clotting factors also increase. White blood cells and red blood cells also increase. These women require more iron. And blood pressure does a little changing as well. It decreases in the second trimester, but by the third trimester, it should be back at a pre-pregnancy level, which is one reason why it's very important to have a baseline of what vital signs, blood pressure and heart rate, are in a pregnant woman. You need a baseline because then in the second trimester it decreases, and by the third trimester, here we are back up to where it is pre-pregnancy state. So we really need to have a good idea of what blood pressure is before pregnancy so that we can monitor closely for what a true pre-pregnancy increase would be during the third trimester, because we want to be able to detect things like pregnancy-induced hypertension very early. So let's go back to the increased plasma volume. Like I said, plasma volume increases by about 50%. And we talked about red blood cells increasing, but they only increase by about 30%. Now, what you should remember is that plasma volume and red blood cells have to do with lab results that we might be seeing on a pregnant lady. So pregnant women can appear to be anemic, but we have to be conscious about what we're looking at lab-wise, because what we are seeing in their lab results may not be a true anemia, but it may be a false anemia, or what's called a physiologic anemia. So if we have an increase in plasma volume by 50%, but our erythrocytes only increase by 30%, then we in turn have a decreased hematocrit, because those two have not increased at the same amount, right? We have changed the ratio of plasma and hematocrit. So our concentration of those RBCs to our plasma volume has decreased. I hope that makes sense to you guys. And so that's what causes this physiologic anemia. So it's not necessarily that the woman has a true anemia, but it's just because of the normal plasma increase and the normal red blood cell increase that makes her appear anemic in lab results. Red blood cells will increase by about 30%. Usually if she's on some type of iron supplement, it should make sense to you, after talking about the respiratory system, why a lady who is pregnant needs more iron. She has an increased demand for oxygen. She needs that to maintain her physiologic state, and also help the baby to grow appropriately. So iron helps us with our oxygen binding capacity, correct? So we need more iron when we're pregnant. Now, if you look back to clotting factors, if our clotting factors in pregnancy are increased, and we've got this big old belly that compresses our inferior vena cava, then we end up with venous stasis because of the belly and just the difficulty of blood getting back to the heart like normal. So the blood may not be used to having to fight against all that resistance or all that weight of the mom's belly to get back to the heart, right? So we have some increased venous stasis. And then if we couple that with the fact that pregnant women also have an increase in clotting factor, then if you think about what risk factors that could happen to her, she's at a greater risk for deep vein thrombosis. So that is something to keep in mind. Hold on a minute, I got to plug this computer in. All right. Now, MSHS. This stands for maternal supine hypotension syndrome. Let's move to the next slide. So maternal supine hypotension syndrome, let's think about what that means for a minute. If somebody is laying supine, that means they're on their back. If they're a mom who is greatly pregnant, then they've got a whole lot of weight that is going to push down on that inferior vena cava. And if we restrict blood flow back to the heart, then we're going to drop blood pressure. So mom can become hypotensive. She will become dizzy. She will become pale, tachycardic, sweaty. She may experience nausea. And this is a bad thing because if we cannot get blood to the placenta because we've decreased our cardiac output, then the baby will start to show signs of fetal hypoxia. And what you will see on a monitor strip is the baby's heart rate will start to go down. You will start to see decelerations on your monitor strip when you're looking at fetal heart rate. So, what you should remember is that our priority nursing intervention, whenever we suspect somebody is experiencing maternal supine hypotension syndrome, is we got to get them off of that inferior vena cava. We have to increase blood flow as quickly as possible. And just the easiest way for us to do that, nursing intervention-wise, is to turn the mom on her left side. Now, turning her on the right side will also work, but if she's already hypotensive, we really want to turn her on her left, because which way does our aorta descend? Think about your anatomy. It descends to the left. So if we turn her to the left, then our body, our heart, does not have to work against gravity to pump out that extra blood or to increase cardiac output so that we can get more oxygen to the baby quicker and to the rest of the body quicker and get her blood pressure up. So we want to turn mom to the left side because that's the easiest way for us to increase that cardiac output quickly. So that would be your priority nursing intervention should you suspect that someone is experiencing this. One thing to note also is that this might not just happen while a mom is lying on her back, but it can also happen if she's sitting in a couch or in a chair. If she has leaned back in any type of position that allows that uterus and the baby to press back on her vena cava, this syndrome can occur. So it does not only occur whenever she's supine. Just an important thing to remember. All right, moving on to the gastrointestinal system. So, one thing that we know about pregnant women is that they have a decrease in peristalsis and gastric emptying. And coupled with that, they also have a relaxed lower esophageal sphincter. Those two things put them at great risk for having reflux. Also, it puts them at risk for having nausea and vomiting and constipation. Also, because of the growing uterus, their stomach becomes displaced, and so do their intestines. They also have high levels of HCG, and progesterone also acts on the gastrointestinal system to cause some of these issues. So what if our woman has reflux? What can we teach her to help her get through this? Because really there's no way for us to increase her gastric emptying unless we're giving her some kind of meds. There's no way for us to unrelax her lower esophageal sphincter. It's just something that happens with pregnancy. So we want to encourage her for nausea and vomiting and reflux to eat small and frequent meals, not to lie down for at least 30 minutes after meals. If she's experiencing that severe nausea and vomiting, we can encourage her to eat some crackers before getting up out of bed. All of those things will help reflux and nausea and vomiting. For constipation, it's really important for moms to stay hydrated. They need to drink lots of water. If approved, it's a good idea for them to get some exercise. And also, Colace is a medication that's safe in pregnancy, so they can also take Colace. Pregnant women experience a lot of gas, and we can give them some simethicone. Simethicone is okay for them to take. And also diet plays a big role in combating gas, as we all know. So it's probably not the best idea if she is experiencing a lot of gas for her to be eating like cabbage and baked beans. And her husband probably won't appreciate that either. So heartburn happens because of reflux, right? There are some medications that pregnant ladies can take for heartburn. They can take Tums and Zantac. Those two things are okay. And I had terrible heartburn with all 4 of my pregnancies, and Zantac was a lifesaver for me. Tums, not so much, because although they helped me initially, they have lots of calcium in them, correct? And calcium does what to your muscles? Calcium causes your muscles to contract. So if we're overloaded with calcium, then we can end up with cramps. And I ended up with leg cramps every night with my first pregnancy because I was eating Tums nonstop. So Zantac worked much better for me. Pregnant women are also at a risk for cholelithasis, or high cholesterol, so we need to encourage them to eat a good diet and to sort of decrease their fat intake so that they don't end up with complications because of that as well. The urinary system also changes in pregnant women. Typically, pregnant women in the first trimester will experience urinary frequency. They will have to go to the bathroom all the time. In the second trimester, that symptom of urinary frequency will start to ease up, but then again, by the end of the 3rd trimester, that baby is pressing on the bladder, and that bladder cannot fill up with urine as readily and as full as it's used to. So in the 3rd trimester, late in the 3rd trimester, they also begin to experience that urinary frequency again. The glomerular filtration rate increases by about 50% in pregnant women. Their sodium reabsorption also increases, and we need a lot of water to perfuse the kidneys. Another reason why it's very important for pregnant women to drink lots of water. That bladder compression happens, like I said, in the 1st and then in the 3rd, late 3rd trimester. The ureters become dilated. Urinary stasis and retention can occur because of that bladder compression and the dilated ureters, and that puts a pregnant woman at risk for urinary tract infections. So that's something that we need to educate them about. Try not to hold your urine for too long. If you feel like you have to go, you need to empty your bladder frequently. The renal glucose threshold in pregnant women is also decreased, and that leads to us seeing trace amounts of glucose on urine dipsticks. Every woman gets a urine dipstick at every prenatal visit. So if we see trace amounts of glucose, we just want to watch that woman a little more, watch her a little closely, but we will not freak out, and that doesn't mean she has gestational diabetes, because a decrease in that renal glucose threshold in the kidneys is normal during pregnancy. So pregnant women have a low specific gravity. They are at risk for those urinary tract infections and pyelonephritis. If they experience those things, it can also lead to preterm labor. So that's important to be able to identify and prevent those two things so that we don't have a mom who ends up in preterm labor that we cannot stop. And then here again, the trace of sugar in the urine on a dipstick just causes us caution, but does not mean that there is something wrong necessarily. The musculoskeletal system also changes greatly during pregnancy. A woman's center of gravity shifts. She has more relaxed ligaments, especially in the pelvis. Her joints relax. Relaxin and progesterone are the hormones that are responsible for this relaxation. And calcium and phosphorus are really important for mom to eat and include in her diet because it's needed by the fetus for to help it produce a good skeletal system. This picture where you see the curvature of the spine in the pregnant woman here, this shows you really how the center of gravity on a pregnant woman does change some. This woman leans farther back, and this is called lordosis, that curvature in the back that you get, curvature of the spine. The term for that is lordosis. So for the endocrine system, the pregnant lady's pancreas produces insulin, right? Everybody's pancreas produces insulin. In pregnancy, it can work a little bit different. Human placental lactogen is a hormone that is secreted during pregnancy, and it's an insulin antagonist and causes diabetogenic effects in the pregnant woman. There's an increase in free fatty acids because mom needs those, right? And that decreases the mom's metabolism of glucose to favor fetal growth. So it affects insulin production. The pituitary gland changes because we start producing oxytocin and not FSH or LH. And remember what FSH and LH do. They help follicles mature and they aid in ovulation. But we have no need for that because we're already pregnant. So the pituitary gland does a different job and produces oxytocin, the main hormone it produces related to pregnancy. The one we worry about is oxytocin, and that helps in labor. It helps with contractions, and it helps with a milk letdown reflex after delivery. The placenta secretes human placental lactogen. It secretes estrogen and progesterone. It secretes relaxin and prolactin. And all of those work in the body to maintain the pregnancy, to help moms make milk, to relax the pelvis. And then, like I said, that human placental lactogen decreases mom's metabolism of glucose so that fetal growth can be favored. And think about that for a minute. We don't want mom to be utilizing all of her glucose that she's taken in. If mom is metabolizing all of her glucose stores or all of her glucose that she's eating, that means there's not anything left over for the baby. So the body is very smart, and the body says, wait a minute, I've got another person that needs this right now. So metabolism changes in a way so as to not eat those stores of glucose up, and instead that human placental lactogen helps us have increased free fatty acids so that we can use up those free fatty acids for mom and save the glucose stores for the baby. Hope that makes sense. The thyroid changes a little bit. It increases in size. The parathyroids also increase in size. Parathyroids, we know, are responsible for our basal metabolic rate. In pregnant women, our basal metabolic rate increases. Parathyroids are also responsible for calcium and vitamin D. We need an increased need for both of those whenever we're pregnant. Our adrenal glands also secrete more aldosterone and cortisol. And the big thing to remember about the pancreas is that it secretes insulin. And in a pregnant woman, she has increased insulin needs. Central nervous system. Pregnant women have a decreased acuity of memory. They have a decrease in concentration because they don't sleep very well. They may have extra stress. They may experience bouts of depression and anxiety because of the changes that are related to pregnancy. That decreased acuity of memory and concentration is sometimes referred to as placenta brain. And I've lived about 36 months of my life with placenta brain. So I know that this actually does happen. And also, our central nervous system is responsible for different types of abnormal activities that happen in people, such as seizure activity, for example. So if we have a pregnant mom who has a history of epilepsy, it's very important for them to stay on their medications or to get on to a type of medication that is appropriate for pregnancy. So we have to work really closely with their neurological specialists that they see. And because of their increased metabolism, their increased basal metabolic rate due to pregnancy, they probably will metabolize whatever anti-epileptic drugs that they are on a lot faster than normal. And it's very important for those type people to understand this, because they need to continue taking their medication, and they actually may need an increase in the dose of their medication. So they need to be getting regular lab draws and serum checks of their medication levels, at least probably monthly, so that that medication can be regulated and so that they don't end up in an epileptic state. Here are a few nursing diagnoses related to psychological and physiological changes during pregnancy. You will oftentimes see health-seeking behaviors, knowledge deficit, a decisional conflict, potentially, especially when we're thinking of psychosocial situations, anxiety, and readiness for enhanced parenting and family processes. Here's a little picture for you guys that talk about the physiological changes in pregnancy, and I hope that this helps break things down for you in just sort of one picture. And now we're going to talk about antepartum gestational onset of coexisting disease processes and how they affect pregnancy. So, what are gestational onset pregnancy alterations? Well, they are either a gestational onset and or coexisting disease processes and alterations in health that are associated with pregnancy and cause a woman to be sort of lumped into a high-risk pregnancy category. So these are issues that we have to pay close attention to because we may have to care for a pregnant woman in a special way related to some of these different alterations. Vaginal bleeding is a big one. This is a bad sign if you're pregnant. Remember the physiological changes in the reproductive system. One of those was amenorrhea. So seeing vaginal bleeding during pregnancy is abnormal. There are some different causes of vaginal bleeding when it comes to pregnancy, and we're going to talk about those now. Abortion or miscarriage can cause vaginal bleeding, and there are different classifications of abortion. We've talked about those earlier, but just quickly to review, we have spontaneous abortions, which are the same thing as a miscarriage. We have elective abortions, so if someone elects to abort a pregnancy. And then we have situations where products of conception can be expelled or not. And if they are not, these ladies may have to have a D&C, or a dilatation and curettage, which is a surgical procedure where the doctor goes in and scrapes out the endometrial lining of the uterus. And these right here on this slide are the two biggies whenever we talk about vaginal bleeding. So abortions and miscarriages usually happen early on during pregnancy, and if it's a very early on in the gestational period, then typically when you see vaginal bleeding, it's because of an abortion or a miscarriage. However, later on during the gestational period, there are a couple of different causes of vaginal bleeding that we are most concerned about as obstetrical providers. One of those is something called a placenta previa, and this is where the placenta implants abnormally into the uterine lining. We talked about implantation and where we want that to occur earlier, and we want that to occur in the posterior upper portion of the uterine wall. That's a good spot because it's away from the cervix and allows a safe passageway for the baby during labor and delivery. Now, if a placenta previa occurs, what that means is that the placenta has implanted very low down in the uterus and is covering part of the cervical os. The cervical os is the opening to the uterus, so it's the hole in the cervix. There are different types of placenta previas. There can be a low-lying one, which just means it's in the lower portion of the uterus. It might not be covering the cervical os, but it's just very close. We can have partial placenta previas where the placenta covers part of the cervical os, or we can have complete placenta previas where the placenta completely, totally blocks the opening of the cervix or the cervical os. And these women end up having to have a C-section because we cannot deliver a baby through a placenta. So they end up having to surgically deliver their babies because of the placement of this. The placenta is a very vascular organ, and when it's not in the right spot, it is at a greater risk for trauma, a greater risk for detachment, and you may see bleeding from that. Another reason that you might see bleeding later on in pregnancy is because of something called an abruptio placenta. And you may hear me refer to this as a placental abruption. That's also another term, or just an abruption. And what happens when you have a placenta abruption is that the placenta begins to tear away from the uterine wall. And this is a bad thing, right? Because the implantation occurs, a placenta grows, and it actually grows into the endometrial lining of the uterus. And that is where all of the exchange of nutrients and oxygenation happens to help the fetus grow. So if a placenta prematurely removes itself from the uterine wall, then it has basically cut off the nutrient and the oxygen, mainly the oxygen supply to the baby. And because the placenta is a very vascular structure, if it starts to separate from the uterine wall, there will be a lot of bleeding. This can occur before or during labor, and it is very, very risky for the mom and fetus. This is probably like one of the worst things that can happen if you are pregnant. And typically, they do not have a very good outcome. So, what are the differences between these two? There are some key hallmark symptoms that will distinguish the two whenever you're looking at it from a nursing assessment standpoint. So, a placenta previa, you will see bright red, sudden, and painless bleeding. The uterus is still nice and soft. These women may experience signs of hypovolemic shock, and it's dependent. Their outcome is dependent on the care they receive from you. In an abruption, these people typically complain of pain. So you will see painful bleeding, a rigid abdomen, hypovolemic shock symptoms, and very dependent on the care. Now, with that said, with a placenta previa, you may or may not see, with a placental abruption, you may or may not actually see the bleeding. If the placenta starts to abrupt from the middle portion, that blood can actually collect behind the placenta, even if it's still attached around the edges. So you might not see that bleeding initially, but you will still see that rigid abdomen, and they will still complain of a lot of abdominal pain. The one thing that causes abruptions are substance abuse, hypertension, abdominal trauma, and cocaine is a huge risk factor. Cocaine use is for placental abruption. If someone comes in and they have vaginal bleeding, especially later on in pregnancy, it is an obstetrical emergency. Anytime there is profuse vaginal bleeding. And your priority intervention is going to be to get your obstetrician to that patient as quickly as possible. So you're going to call that OB stat. Because you are, as the nurse, are not able to diagnose the problem. You might know exactly what's going on, but you can't fix it without the OB being there. The people who come in with placental abruptions end up having to have stat C-sections. They have a very, very limited amount of time to get that baby out and stop the bleeding from mom to have a good outcome. All right, so we actually just talked about all of these things, and I just forgot to flip the slide. But again, just to review, the criteria for comparison and contrast between placenta previa and abruptio placenta are the characteristics of the vaginal bleeding, okay? So painless and painful, the different signs and symptoms that we talked about, like soft uterus or rigid abdomen, and the pregnancy outcomes for previas versus abruptions. They're much better for previas than they are for abruptions. And the prognosis for the fetus. Usually if someone has a previa, we can manage that much better than we can if it's an abruption. All right, ectopic pregnancy. So what is this? This is, by definition, an extrauterine pregnancy, so outside of the uterus. There are different places that an ectopic pregnancy can implant itself. It can implant inside the fallopian tubes. It can implant itself inside the ovary, or even inside the abdominal cavity. Okay, I'm sorry guys, it's 11 o'clock, so this grandfather clock is going to ding 11 times. I'll just wait for it to finish. And there's another one going off. My husband is obsessed with clocks, so we have about 4 of them that go off every hour. It's ridiculous. Okay, that one's not quite as loud. So what causes ectopic pregnancy? Different things. Pelvic inflammatory disease can cause scarring that does not allow the free sort of roaming or movement of a fertilized egg. And if that's the case, then these people are at higher risk to have ectopic pregnancy. People who have had bilateral tubal ligations, they are at a greater risk for ectopic pregnancy. People with an IUD, contraceptive device, people with endometriosis, both of those because of scarring. Past history of ectopic pregnancy, they're more likely to have an ectopic pregnancy in the future. And in people who have structural anomalies of their fallopian tubes, also sort of mess up that passageway for a fertilized egg, so they're also at a greater risk. This is an obstetrical emergency. If somebody comes in with an ectopic pregnancy, we got to get the doctor there because they have got to have surgery before they're, hopefully, they've made it to the emergency room prior to a fallopian tube rupturing. This requires emergency abdominal surgery to remove the pregnancy. These people present with intense abdominal pain, and they may or may not have vaginal bleeding. But if they end up with a ruptured fallopian tube or something of that nature, they can develop hypovolemic shock very quickly if they are not managed appropriately. So remember what your signs and symptoms of hypovolemic shock are. We've talked about it twice now. We've talked about it with previa, abruption, and now with ectopic pregnancy. Hypovolemic shock is a big thing in pregnancy. So what are they? Anxiety, decreased urine output, profuse sweating, shallow breathing, dizziness, confusion, a decreased level of consciousness. They have hypotension. They have tachycardia. You might assess a weak pulse. These people have a doom and gloom. They have an impending sense of doom that something's not going well. And to manage this prior to the abdominal surgery, we've got to get their blood volume back up, right? We've got to give them some volume so that they can have some type of circulation. So an IV bolus, they need surgery. These people may have to have blood transfusions. Gestational trophoblastic disease is another complication that happens in pregnancy, or this is actually not a pregnancy. It it is called a molar pregnancy, or you may hear it called a hydatidiform mole, an invasive mole, or a choriocarcinoma. There are a whole lot of different names for it. But in essence, this is just an abnormal overgrowth of the trophoblasts. These people have all of the symptoms of pregnancy. They have an enlarged uterine size, but usually the uterus grows a whole lot larger than it's expected to in a certain time frame. The hallmark sign that this is happened to someone is dark brown vaginal bleeding. And sometimes that bleeding may include the passage of these little grape-like vesicles. On an ultrasound, you will not see a skeleton because there is no baby. It is just all of these little grape-like vesicles. These people are at a huge risk for cancer. And all of this has to be surgically removed, and then it's required that these people be on birth control for at least 1 year, because we do not want them getting pregnant within a year time frame if they're ever diagnosed with this, because they have a great risk for cancer development if they do. So we monitor their HCG levels for a year, and we put them on birth control. We have to do a lot of education with these people. Hyperemesis gravidarum is severe nausea and vomiting. So this is it's an excessive complication of the GI system that happens in pregnant women because of that elevated level of HCG. Oftentimes, these people have to be hospitalized because they have to have hydration, because they don't even tolerate water. So we bring these people into the hospital, we IV hydrate them. If it's severe enough, they may have to go on TPN. We make them NPO. We do very strict eyes and O's. These people can end up in a fluid electrolyte imbalance and severe dehydration, which can cause cardiac issues and also can cause severe problems for the fetus. And so your priority nursing diagnosis here, obviously, is fluid volume deficit. Group beta strep infection is exactly what that says. It's a group B streptococcus infection, but it does not affect the mother. Group B strep, or GBS, is a normal bacteria that women carry in their vaginal canal and in their rectum. But when it becomes overcolonized, then it can be transmittable to the fetus and the neonate. It can also be transmitted from one healthcare provider and other infants. We test all pregnant women for the presence of GBS infections between 35 and 37 weeks gestation. And the reason why we want to know if they are positive for GBS or not is because these ladies have to have prophylactic antibiotics during labor. Now, like I said, this doesn't cause any sort of signs or symptoms for the mother. It doesn't affect the mother in any way, but it is a grave risk to the baby during delivery. So for these women who are positive, we give them penicillin G, or if they're allergic to penicillin, we might opt to use clindamycin, and we give them IV doses of those drugs during labor, all the way through their labor until delivery. And then after delivery, we discontinue it. And the reason we do that is prophylactically to prevent the baby from getting this infection. Complications from getting this infection in a newborn are pneumonia, sepsis, respiratory distress syndrome, and even meningitis. It can be very severe and make them very sick, and newborns can actually die from this, so it's very serious. We said that pregnant women are at a greater risk for urinary tract infections because they already have those physiological changes where their bladder retains urine. They have those dilated ureters, and so we want to pay attention to this whenever we're doing urine dipsticks in the office on their prenatal visits. Urinary tract infections in their most severe form are a result usually of pyelonephritis. And these ladies will present with a very high fever, and they are at risk for preterm labor and intrauterine growth retardation. That's what IUGR stands for. So we do not... These ladies, for some reason, whenever you get a urinary tract infection, it tends to make your uterus very irritable. And whenever a uterus becomes irritable, it will start to contract, which is why UTIs can cause preterm labor. We give these ladies antibiotics. We follow up with a culture and sensitivity to make sure that the antibiotics they're taking are appropriate for the organism that's caused the infection. But more than that, we really want to prevent these infections before they happen. If they do happen, we want to treat them very early so that we can prevent any preterm labor or early delivery of a baby. Hypertensive disorders. This is a big one, and we have to consider, does mom have already hypertension prior to pregnancy, or is she developing it during pregnancy? Preeclampsia is a hypertensive disorder that is developed during pregnancy, and the way that we diagnose preeclampsia is if blood pressure is increased after 20 weeks, along with proteinuria. So those two things coupled together, an increased blood pressure after 20 weeks and proteinuria, will cause a woman to have the diagnosis of preeclampsia. Eclampsia is the most severe form of preeclampsia. It's the most severe hypertensive disorder in pregnancy, and what classifies someone as being eclamptic or having eclampsia is that they have seizures. So eclampsia, people with eclampsia have seizures that are related to that high blood pressure. Now, let's think about the proteinuria in preeclampsia. Why does that occur? Well, people with high blood pressure typically tend to have damaged blood vessels. Now think about the blood vessels in your kidneys. If we have damaged blood vessels and they're damaged in the kidneys, then the kidneys will not hold on to protein. Normally, the kidneys will hold on to protein. But if the vessels are damaged, then protein will spill out of the kidneys and into the urine. And that is abnormal sign. So that tells us that someone has reached a hypertensive level to the point that they're having protein spill into the urine. Okay, so we can call them preeclamptic. Now, I just lost my train of thought. Let's move on to seizures, and then maybe I'll remember. So let's think about seizures in much of the same way. Damage to blood vessels due to hypertension. But now let's move on to the central nervous system. So think about the brain. If we have damaged blood vessels in the brain, then we're going to end up with edema in that area, and that can restrict blood flow. That damage to the vessels can restrict blood flow, causing edema in the vessels, and then we end up with seizure activity, okay? So think of this hypertension in ways that affects those blood vessels and damage them, and that's why we're seeing protein in the urine and why we might eventually see eclampsia or seizures in the most severe form. These people also have swelling. So they have dependent edema. You'll see it in their feet, in their hands, and they will also have facial edema. And that used to be a diagnostic criteria that went along with preeclampsia, but it is no longer, because if you think about pregnant women in general, they tend to hold on to sodium and swell and have edema anyway, so it wasn't really a good diagnostic characteristic. But for these people that have preeclampsia and eclampsia, you will see that in them, that edema in the face and the legs and the hands. Now, moving on to ABO incompatibility. We've talked some about positive and negative blood, but now let's talk about type. So what happens with ABO incompatibility is when a mother who has type O blood conceives a baby that develops type A, type B, or type AB, if that blood somehow is cross-contaminates, the mom will begin to make antibodies that attack the antigen of the fetal red blood cells. And if that happens, then basically mom is killing off the red blood cells of the fetus. And so those red blood cells will burst, or they experience hemolysis, okay? Now, the end result of that is that the baby can end up with hyperbilirubinemia or hemolytic anemia. Hemolytic anemia just means that the mom's antibodies have killed off the red blood cells to the point that the baby is severely anemic. And that's a really bad thing to happen. Because the baby, the hemolytic anemia breaks down those red blood cells in the fetus much faster than the fetus's bone marrow can produce replacements for those red blood cells. And so essentially this can cause fetal death. Now, hyperbilirubinemia happens because there's too much bilirubin in the blood due to the breakdown of those red blood cells. Babies do not excrete bilirubin as well as adults do, so they end up with this high level of bilirubin in the blood, and that can actually cause neurological issues for a fetus or a newborn. Now, take a picture, take a look at this little picture down here underneath this slide. And I want you to take note of this picture. So this picture is actually describing the difference between positive and negative blood. But let's take a look at this mom. She has a negative blood type for the first baby. Okay, now somehow the baby and the mom have been cross-contaminated, and the mom has made some antibodies that against the baby's positive cells. Now, the immune system will start to make those antibodies and attack those positive cells. If this mom gets pregnant again, then her body is going to recognize a foreign invader if the baby is positive, and her body will start releasing those antibodies, those soldiers, to kill off that what it thinks is an invader of positive blood cells, but it's actually the baby. So that's how this hemolysis of fetal red blood cells happens. And this is why a mom needs a RhoGAM. All right, so now recall the importance of our blood typing. We just talked about the different types of blood. So now we're going to talk about positive and negative. Now that picture that we just talked about does explain positive and negative. I just did not have room for it on this slide, so it's on the previous one, okay? This occurs when an Rh negative mom conceives an Rh positive fetus, and this occurs in succeeding pregnancies. The mom develops antibodies that attack fetal positive red blood cells and cause them to die or hemolysize. The result is that the baby ends up in hemolytic anemia, like we just discussed, or may have hyperbilirubinemia because as those red blood cells are killed off, bilirubin builds up in the blood, the baby cannot excrete it, and they end up with a neurological issue if it becomes severe enough. It's neurotoxic to the brain. Also, edema is another thing that can happen. The baby might end up with hydrocephalus. That's where you might have heard these babies called waterheads. Congestive heart failure can also occur in the fetus. So how we manage this is we give the Rh negative mom RhoGAM, which is an RhD immunoglobulin. We give it intramuscularly. It is a shot, and she gets it at 28 weeks. And then if the baby is a positive blood type, she'll also get it 72 hours after, at least within 72 hours after she delivers. Now, a third time that she may receive RhoGAM is if she's having some kind of invasive procedure that might put her at risk for cross-contamination between her blood and baby's blood. So, for example, like an amniocentesis, or if she has to have a surgery of some kind, she would also get RhoGAM at that point. I know this is a very complicated to sort of understand. Blood typing is difficult anyway. But what I really want you to understand is why hemolytic anemia occurs, why hyperbilirubinemia occurs in regards to blood type and the negative and positive parts of blood between mom and baby. And I want you to understand why we use the RhoGAM for negative moms. Torch infections are also complications that can occur during pregnancy. We might see moms who have toxoplasmosis. Toxoplasmosis is an infection that occurs, and usually you get this from cat litter. This is why we encourage moms not to change cat litter prior to trying to get pregnant or during pregnancy. These moms have flu-like symptoms, and they might not be severe for the mom, but for the baby, they cause neurological damage and can actually cause fetal demise, and then mom ends up with a stillbirth. Rubella, or German measles, also will cause birth defects for a baby, heart problems. They might end up with congenital rubella syndrome, vision problems, hearing problems, bone growth. It can mess up a whole lot of stuff for the fetus. So it's very important that we check to see if moms are immune to rubella. And that's one reason why we want to know if their MMR is up to date or not. So we will draw a titer for all moms and check their rubella status. Now, moms cannot receive if she's not immune to rubella. So if her childhood vaccine has worn off and she is no longer immune to rubella, and we find that out during her pregnancy, then she cannot receive MMR vaccine because it is a live vaccine. Remember back to your health promotion lecture. So what we have to do is educate her to stay away from people who may have this, or people that she knows may have this, and then we need to educate her that she needs to receive this MMR vaccine after delivery. And typically we will give it prior to her being discharged from the hospital. Cytomegalovirus is something that is part of the herpes family, and usually the mother have no symptoms of this, but it will cause congenital cytomegalovirus infection in the baby. They will end up with inflammation of the retina. They can have jaundice, large spleen or liver. They might have low birth weight. One of the key signs of this is that they have a rash at birth. They might have microcephaly, seizures, or little brain calcifications. And this picture that you have here is a picture of all of the different things that can happen with cytomegalovirus. And then herpes, or HPV, occurs with moms that have this sexually transmitted infection, and somehow it is passed along to the baby. One way that we try to prevent this as healthcare providers is to make sure that if the mom is having an active outbreak, that we take her for a C-section and not allow a vaginal delivery. And that is for protection of the baby. Gestational diabetes. We talked a little bit about how the pancreas and endocrine system changes in pregnancy, and we know that moms need an increased need for insulin. Gestational diabetes is a type of diabetes that develops at the midpoint during pregnancy, and there are several high-risk groups of people to look at whenever we are thinking about pregnant women who might come down with this. People who are obese, over 25 years old, they have a history of large babies, a family history of diabetes, they're of Native American, Asian, or Hispanic descent, and this can cause unexplained fetal deaths. These babies typically tend to grow really, really large, really, really fast. The mom's blood brings extra glucose to the fetus. That helps the baby grow. In gestational diabetes, the fetus gets extra glucose that it is not typically going to get in just a normal pregnancy. The fetus makes a whole lot more insulin to handle that extra glucose, and then the extra glucose gets stored as fat, and that's why the fetus becomes a lot larger than normal. Sorry, you guys, I had to yawn. All right, let's look at this other little picture here and talk about it. So the pancreas is, in this disease, the pancreas is unable to produce enough insulin to counteract that hormone that we talked about, human placental lactogen, HPL. and that leads to an increase in sugar levels, and it causes gestational diabetes. So I hope this little diagram makes it clear to you how this works. So like I said, pregnant women already need have an increased need for insulin. Now, let's think about this in terms of after delivery. All right, after delivery, our placenta is gone. And if what is causing this, insulin resistance is that hormone produced by the placenta, once we get rid of the placenta, that barrier is gone. So these women don't have the same needs as they did when they had their placenta, right? So if they needed insulin prior to delivery because of gestational diabetes, then after delivery, typically their insulin resistance is not going to be as bad, and they will not need insulin. So if we have somebody who's a pregnant mom and she's been on insulin coverage to control her gestational diabetes, as soon as she delivers, we do not continue giving her insulin. We discontinue her insulin, and we monitor her blood sugars. We monitor her fasting blood sugars, and we monitor her postprandial blood sugars, typically 2 hours after every meal. And if we see the need at that time for her to continue having some kind of supplement to reduce her blood sugar, usually we'll put on oral hypoglycemic, not necessarily insulin. So it's important for you to understand that, because their insulin need is much greater prior to delivery of the placenta due to that hormone. And then once the placenta is gone, that hormone level drops drastically immediately, so they don't have that need any longer. Okay, so they have an increased need for insulin during pregnancy, and then immediately after pregnancy, that increased need for insulin immediately drops off. So why do we screen for gestational diabetes? The reason why is because these people are at greater risk for many other things. They are at a greater risk for pregnancy-induced hypertension. They are at a greater risk for yeast infections. Yeast love a nice, sweet, sugary environment. They're at a greater risk for urinary tract infections, for those large babies, that those babies can have congenital anomalies. Stillbirths can occur, and abortions as well. So we want to catch it as early as we can. All right, now what about how do we screen for this? Well, we use oral glucose tolerance testing, and this is the screening test for gestational diabetes. We take their blood fasting at 24 to 28 weeks, and so they have to schedule this test. So they come in, they get a fasting blood sugar drawn, and then they have to drink this nasty stuff called, it's basically just glucose. And for the 1 hour glucose tolerance test, which is the first one everybody takes, they drink a 50-gram glucose load. And then they have a venous sample of their blood drawn at 1 hour after drinking that 50 grams of glucose. If their level is greater than 140, then we have to test them again, basically. If it's greater than 140, then we're going to schedule them for a 3-hour glucose tolerance test. But this time, they are lucky enough to get to drink 100 grams of this glucose drink, and they'll have their fasting one drawn. They'll drink their 100 grams of glucose. Then they'll have their blood drawn at 1 hour, 2 hours, and 3 hours to see how their insulin is working to decrease that glucose. With that 3-hour GTT, if 2 of those 4 blood draw results are abnormal, then that lady is diagnosed with gestational diabetes. So here is just an example of impaired glucose metabolism. This is a state between normal and diabetic. Fasting blood sugar is 110, but under 126. Greater than 110, but under 126. I apologize. The oral glucose tolerance test might be 140, but under 200 on a 2-hour blood sample. So you can kind of look at this little chart here and look at those numbers between normal, pre-diabetes, and diabetes. Sexually transmitted diseases. This includes all of those things that we talked about in individual module 4. We know that we test all pregnant women for chlamydia and gonorrhea. They all get an HIV and AIDS or HIV test, and they all get a syphilis test, which is that RPR. If ladies have herpes and they have an active outbreak, then they are going to have a C-section delivery. We are not going to allow them to deliver a baby vaginally if they have an active herpes outbreak. And if mom does have an active outbreak, we do a C-section and we have the newborn there. We just use standard precautions whenever we're caring for the newborn. There's no need for that newborn to be separated from the rest of the nursery. There's no need for us to use any kind of sterile procedures or contact precautions or whatever. We just use normal standard precautions. So how would we treat HIV and AIDS during pregnancy, and what are the possible outcomes for the fetus after delivery? Well, anybody who is positive for HIV, we want them to continue on their antiretroviral drugs during pregnancy because it greatly reduces the risk for the baby to contract HIV if the mom stays on her ART therapy. Because the incidence of sexually transmitted diseases are so high, that is why all prenatal lab profiles include testing, and it is mandatory because this protects the fetus in the outcome. And we know that there's an increased incidence of STDs because many people are asymptomatic and transmission occurs between people because they don't know they're infected. Here are a few nursing diagnoses to consider for people with complications. They may have knowledge deficit, deficient fluid volume with the hyperemesis gravidarum, risk of fetal infection with GBS status, imbalanced nutrition related to gestational diabetes, acute pain with the ectopic pregnancy or placental abruption, anxiety related to their abnormal diagnosis, antepartally. So try to think about all of those things and how they apply to each of these different complications. And this is the end of this presentation. This is PowerPoint 2, and this is Lecture 2 for Individual Module 5.1. Thanks for listening.